You may have never heard the term dead volume, or even one of its other names like shared infusion volume, common volume, dead space, or downline volume. The topic is not often explicitly discussed. However, dead volume is a very important topic whenever two or more IV infusions join together, whether flow is being controlled by a large volume IV pump, syringe pump, or delivering an IV push bolus by hand. Dead volume is the volume shared by multiple IV infusions when they join together, creating a single pathway to the patient's bloodstream. Being cognizant of dead volume is very important for delivery of life-sustaining medications with short half-lives, such as cardiovascular drugs. When multiple fluid paths converge into a single line, their flow becomes dynamically linked, leading to complex interactions where flow rate changes to any one infusion will influence the delivery of all the infusions. These interactions can lead to unintended boluses, delays, and variations in the delivery rate of potent drugs, resulting in unintentional clinical effects for our patients. Throughout both modules in this series, we will express the delivery rate in terms of a flow rate in milliliters per hour. While we recognize that it is much more common to express delivery in terms of a dose rate, to introduce dead volume, it is easier to initially conceptualize the delivery in terms of a flow rate. As we explore the concept of dead volume in this module, we will answer the questions, what is dead volume, and how does dead volume affect medication delivery? Part 2 will continue our discussion of dead volume and answer the question, how do you minimize the impact of dead volume? By appreciating the complex features of dead volume, we will see how it has the potentiality to critically impact the well-being of our patients. The topic of dead volume is particularly relevant for any situation where potent drugs are being delivered at low flow rates. To start understanding dead volume, we should build up from a relatively simple scenario. An adult patient was in septic shock. To help combat the patient's low blood pressure, an infusion of vasopressin is to be added to supplement an ongoing infusion of norepinephrine. The only free port available to attach the vasopressin is the lower Y site of the norepinephrine infusion. 2 milliliters of tubing exist between this port and the patient's bloodstream. The norepinephrine is running at 7.5 milliliters per hour. The vasopressin is to be started at 0.6 milliliters per hour. After starting the vasopressin, how long do you estimate it would take for the patient to start receiving it at the programmed rate of 0.6 milliliters per hour? That is incorrect. In the slides ahead, we will see why it would actually take more than 15 minutes before the patient starts to receive the vasopressin at 0.6 milliliters per hour. That is correct. When we attached the vasopressin infusion, it created dead volume, highlighted here in red. In reality, we cannot visually discern what is happening in the dead volume, but in this module, we will make the invisible visible by using colors to illustrate how our medications are moving. In this case, we will color the vasopressin green and keep the norepinephrine blue. At this time, the dead volume only contains norepinephrine. When we start the vasopressin pump, it starts to push vasopressin into the dead volume, but it must fully propagate through the dead volume before it actually starts to reach the patient. Let's refer to this propagation as clearing the dead volume, as you are essentially clearing the old contents from the dead volume and replacing them with a new mix of the medication. The time to clear the dead volume, meaning how long it takes before the patient starts to receive the medication at the programmed flow rate, will depend on a couple of factors. One factor dictating how long it takes before the dead volume is cleared is the size of the dead volume. Dead volume is the combined volume of all the IV components, from where multiple infusions join together up to the patient's bloodstream. This includes the IV tubing, catheter, and any connectors and extension sets present in the setup. The exact size will depend on the specific infusion setup, components used, and your hospital protocol. For this setup, the dead volume is 2 milliliters. The time to clear the dead volume is also dependent on the flow rate through the dead volume. Individual fluids within the dead volume do not flow as separate, independent fluids. As the medications flow into the dead volume, they mix, and the mix flows at a rate that is the sum of all the joined infusions. This flow rate change occurs immediately whenever an infusion is added, removed, or the flow rate changed. The slower this flow rate, the slower the dead volume is cleared. In this scenario, our dead volume is about 2 milliliters, and the flow rate through the dead volume is 8.1 milliliters per hour. As a result, the vasopressin will only be slowly propagating through the dead volume once it is started. In fact, it will take over 15 minutes before the vasopressin makes its way through the dead volume and starts to be delivered to the patient at the programmed rate. This delay in delivery is one implication of dead volume. Another implication is that whenever an infusion is added, removed, or a flow rate changed, the flow rate in the dead volume instantly starts flowing at the new combined rate. However, the composition of the dead volume does not change instantly. In our scenario, let's jump back to the moment we added the vasopressin. Prior to starting the vasopressin, only norepinephrine was in the dead volume, flowing at 7.5 milliliters per hour, exactly as programmed on the pump. Starting the new vasopressin infusion instantly increases the flow rate through the dead volume to the combined 8.1 milliliter per hour rate. After starting the new infusion, the norepinephrine initially in the dead volume is suddenly being delivered faster than the flow rate programmed on the pump. This increased delivery of the norepinephrine occurs for as long as it takes the dead volume to be cleared and replaced with a mix of the two medications. For this specific case, these two implications mean that after the vasopressin is started, despite what the pumps display in terms of flow rate in reality for at least 15 minutes, 1. The patient is not receiving the vasopressin at the programmed rate, and 2. The patient is receiving the norepinephrine at a faster delivery rate than programmed. Here are graphs illustrating the intended delivery rates as programmed on the pumps for both medications following the addition of the vasopressin, compared to the actual delivery rate received by the patient over time. For simplicity's sake, we have chosen to illustrate these graphs and visualize flow through the dead volume using what is called the plug flow concept. This concept assumes that the different medications mix perfectly at the point where they join and travel along, like a wall of new fluid in the proper proportions. Thinking of flow this way may be oversimplifying the mixing dynamics and may underestimate the amount of time between when an infusion is added, removed, or titrated, and the change reaching the patient. An alternate way of predicting the flow is with the well-mixed concept. This concept assumes that the concentration of drug within the dead volume instantly starts to mix, but only gradually mixes to the proper proportions. As a result, it predicts a more smooth and gradual return to the intended delivery rate, but taking about 3 times as long as the plug flow concept. It's hard to say which way of thinking about flow best predicts the time delay caused by dead volume, but it likely will be somewhere in between the two concepts' predictions. For the sake of simplicity, we will continue to visually show and estimate the flow as if it were traveling as a wall of fluid. However, be aware that within this module, the time to clear the dead volume values may be an underestimate. It may actually take 2 to 3 times longer than the values stated. Let's say our setup has now been infusing for over an hour. The amount of each medication in the dead volume mix is proportional to how fast it is entering the dead volume. This proportional mixture is how, despite the flow rate through the dead volume being an additive combination of the rates, the amount of each medication delivered can match its programmed dose rate. A drug infusing at a slower programmed rate will make up a smaller proportion of the dead volume mix than a drug at a faster programmed rate. there is an order to increase the vasopressin flow rate to 3 milliliters per hour. This change is made on the pump. Remembering that the contents of the dead volume cannot change instantly, but the total dead volume flow rate does change instantly. Compared to the rate programmed on the pump, what is the delivery rate at the patient's bloodstream immediately following the change? That is incorrect. In the slides ahead, we will see why the patient temporarily received more norepinephrine than programmed on the pump, and there was a delay before they started to receive the vasopressin at the new 3 milliliters per hour rate. That is correct. Visualizing why this occurs can be difficult, so to make it a bit clearer, we will look at a segment of the dead volume and represent the composition as bands of color. The height of the bands represents the proportion of each individual medication in the mix. Before the rate was changed, the dead volume contained both the medications in a ratio corresponding to the pumps running at 0.6 and 7.5 milliliters per hour. Making a change to the delivery rate on the pump means the composition of the dead volume has to change. In this case, significantly increasing the vasopressin delivery rate means more of it needs to be reaching the patient, and as such, needs to take up an increased proportion of the dead volume. However, this change in composition is not instantaneous throughout the dead volume. The old composition must first be cleared from the dead volume, meaning there is a delay before the change is reflected at the patient's bloodstream. While the composition does not change instantly, the flow rate through the dead volume does. The old composition is now flowing faster, and it is not mixed in the appropriate ratio for this new rate. The old composition has more norepinephrine and less vasopressin than the new mix. As a result, until the dead volume is cleared, the patient is receiving a bolus of norepinephrine, and the vasopressin is not yet being delivered in the proportion corresponding to the newly programmed rate. After some time passes at the new rate, the patient seems to be responding well, so it is decided by the care team that the vasopressin can be stopped. About 5 minutes after stopping the vasopressin pump, what would you expect is being delivered to the patient's bloodstream? Despite stopping the vasopressin pump, the patient will still be receiving vasopressin for a period of time. In addition, they will be receiving slightly less norepinephrine than programmed on the pump. Let's see why this is on the next slide. That is correct. When there is dead volume, stopping an infusion does not mean the patient instantly stops receiving that medication. It can persist for several minutes to even an hour depending on your IV setup. The medication that was stopped needs to be pushed out of the dead volume. Furthermore, you have suddenly reduced the flow rate through the dead volume by stopping a pump, so all the other medications present within the dead volume are now moving slower, meaning the patient is receiving a reduced amount of those drugs. The effect on delivery will be more substantial when stopping an infusion at a high rate. Based on the 3 scenarios we've discussed so far, we can summarize what occurs when dead volume is present with 3 simple rules. The scenarios we've explored so far only involved 2 infusions connected together. However, for critically ill patients, it is not uncommon for them to be receiving several critical infusions simultaneously, frequently joined together using something like a multi-port connector. In the slides ahead, let's see how well the 3 rules apply to more complex situations, like this case with an infant patient. What is entering the patient's bloodstream 1 minute after we add a dopamine infusion? Assume the other 3 medications have been running for a while now. Prior to starting the dopamine infusion, there was no dopamine in the dead volume. The dopamine needs to propagate through the dead volume before it reaches the patient's bloodstream at the rate programmed on the pump. Also, adding the dopamine infusion increased the total flow rate through the dead volume. As the new mixture enters the dead volume, it will be pushing the old composition to the patient at an increased rate. Therefore, as the dead volume clears over at least 25 minutes, no dopamine is being received, and the patient is receiving an increased amount of everything else. That is correct. After some time has passed, the patient's blood pressure has risen a bit too much, so the delivery rate of the dopamine is decreased. Compared to what is shown on the pumps, what is being delivered to the patient immediately after decreasing the dopamine delivery rate? After making a change on the pump, it takes time for the previous proportion of medications to be cleared from the dead volume. The result is a delay before the patient receives the dopamine, mixed in the proper proportions to correspond to the new 0.9 milliliter per hour rate. In addition, decreasing the delivery rate of one infusion decreases the total flow rate through the dead volume. So the delivery rate of all the other infusions will temporarily decrease from what is shown on their respective pumps. This will last for at least 28 minutes as the dead volume clears. That is correct. Finally, after some time, it is decided to start the process of easing the patient back to consciousness. So the vecuronium is stopped. Compared to what is programmed on the pumps, what is being delivered to the patient immediately after stopping the vecuronium infusion? Despite stopping the vecuronium pump, vecuronium remains in the dead volume and will continue to flow to the patient as it is cleared from the dead volume. Meanwhile, stopping the vecuronium pump suddenly decreases the total flow rate through the dead volume. The medication mix in the dead volume prior to the change is moving slower, thereby delivering a decreased amount of the other medications as the dead volume clears over the course of 31 minutes. That is correct. In summary, when treating patients receiving multiple rate critical medications with short half-lives, it is often essential that we have uninterrupted, consistent flow of these infusions. However, dead volume can complicate how we achieve this. Dead volume is created whenever we join two or more infusions together, such that they share a single pathway to the patient's bloodstream. The implications of dead volume are particularly important when delivering medications that are highly concentrated, have short half-lives, are being infused at low flow rates, or require frequent titration. Remember, when dead volume is present, we know that the following is true immediately after an infusion is added, removed, or titrated. That concludes part 1 of this 2-part series. You should now know what dead volume is and appreciate its potential to significantly impact the safe and timely delivery of medications. Part 2 will discuss how we can take steps to minimize the impact of dead volume during critical drug deliveries.